unSILOed podcast is produced by University FM, elevating the stories of your institution.
Welcome to unSILOed. This is Greg LeBlanc, and I'm here today with David Ansell, who is professor of medicine at Rush University Medical Center in Chicago. Also, I guess, senior vice president and associate provost for community health equity, which, I mean, that's got to be a unique position. I don't think that every hospital has a person in charge of community health equity. Also the author of a couple books. Your first book was called County, Life, Death, and Politics at Chicago's Public Hospital. And the more recent book, which I guess it's the second edition that just came out, it's called The Death Gap, How Inequality Kills. Welcome, David.
Thank you.
So this book makes a number of points. I think the primary point is that there are a lot of people in the United States that have a standard of life which is substantially below that of people in, third world countries, right? There are some people who have exceptionally bad health, and it's concentrated, right? And we have these huge divisions that are based on income, based on race, and based on geography. And I think part of the point, and I hope we can dig into this, is that it's not simply the existence of poverty, but it's inequality, independent of poverty,
Exactly.
that is driving a lot of this. And I think another main point is that when we think about healthcare, we tend to think of it in terms of what hospitals are doing and what doctors are doing. But in fact, the main determinants of health occur outside of the healthcare system, right? In the community, in the lived experiences of the people before they ever even encounter a healthcare practitioner. So I think this book was inspired by your work, and you joined you went to Chicago. You're from New York, but you went to Chicago. Did you immediately start working in some of the poorest communities? You've worked in both. You've had patients in the wealthier communities and the poor communities, and so you've seen sort of the differences across these different folks.
Yeah.
Sometimes even on the same day. I think you said you could walk from one hospital to the next and get a completely different group of patients.
Yeah. I knew something was wrong in medical school, but I couldn't put my finger on it. And a group of us decided to go, medical students, feeling the same way. We had, on our own, decided to study the U.S. healthcare system. Now, think 1975, 76. And we decided that we would land ourselves at Cook County Hospital in Chicago, the famous or infamous public hospital in Chicago that was on the verge of closing. It was at the intersection of, we thought, health and society, and what a better place to train. Maybe we would learn medicine. Maybe we'd help keep the hospital open. And that's exactly what happened. The hospital stayed open. We learned medicine. I stayed there for 17 years. And then I got recruited to go to the largest private safety net health system in Illinois, which was called Sinai Health System, a formerly Jewish hospital system in a black neighborhood. This is the neighborhood that Ta-Nehisi Coates wrote about in his famous article in The Atlantic, The Case for Reparations. And being in that vantage point of that hospital, looking out my window, I could see two towers. And when I dug into it, one of them was the Sears Tower, and the other one was Weston Electric. And I understood something about the legacy of structural racism in this country with redlining and all those redlining, blockbusting, white flight, was that it wasn't just that white people left the neighborhood. The businesses left the neighborhood, left people then without insurance and impoverished and then without health nor wealth, they died early. And I got that insight, and then I got recruited to Rush to be the inaugural chief medical officer. And it was almost as if I'd left the concert and my ears were still ringing. I said, what happened in this past 30 years? Because people in Rush at that time had no idea that outside our doors it was one street. We're literally along one street of Chicago, in Chicago, Ogden Avenue, one street, two worlds, three hospitals, three entirely different experiences.
Now, look, the metric of life expectancy, I mean, it's probably the easiest one to track. And so you kind of focus on that. I mean, it's clearly there are other things that matter, like quality of life, right, while one is alive. But why do you think that life expectancy serves as a good measure of these disparate health outcomes?
Yeah. Well, I want to talk about life expectancy and then a little bit about thinking about causation. And maybe I'll talk about the causation piece a little bit because it gets to sort of what measures are important. You know, along the way, this experience of one street, two worlds, which I can get into a little bit more how to play it out in the bodies and experiences of patients. But this idea of one street, two worlds in these observations that where you live, particularly if you lived in concentrated disadvantage, dictated not only the quality of your life, but the quantity of your life, was not what I had learned in medical school, and it was not how any of the organizations I was in was oriented. And so I'm experiencing, you know, a spiritual disconnect. Even as I advanced in my career from being a division chief of internal medicine and primary care at County, chair of a department at Mount Sinai, and now the inaugural chief medical officer at Rush, I'm experiencing a crisis that the paradigms that not only I was trained in, but I'm defending were incorrect or insufficient. Let's put it that way. I don't want to say they were completely incorrect. You know, there was value there, but insufficient. And I think life expectancy becomes then a way to think about it. How, you know, so I got in front of the board at Rush. When I made this transition, I quit my job as chief medical officer. We're U.S. News and World Report honor roll hospital. My job as CMO, the first, was to make us top in quality. We were top in quality. Newsweek ranks us one of the best hospitals in the world. Why would you quit your job when most CMOs are carried out stiff, boots first? You know, and I quit my job because I had this crisis. It was a moral crisis that of solving the wrong problem. And I got in front of the board as in saying, if you lived in the loop in Chicago, this was our community health needs assessment summarized, distilled. If you lived in the loop, you could live to be 85 or in the north side of Chicago. And if that were a country, it'd be ranked first in the world. But you go down the blue line, 7 stops, 3 stops past Rush, our backyard, life expectancy in Garfield Park at the time plummeted to 69. Now it's 66 post-COVID. Garfield Park now, were it a county in the United States, would be the lowest life expectancy county. Think Pine Ridge, Sioux Nation. Upper East Side of New York, a few miles, Pine Ridge. And the life expectancy, imagine what it's like not to have those years. What does it mean to a family, to that premature mortality? And then the mother way that I began to frame it, not just so life expectancy becomes a great way to think about not only why do those gaps exist so close to each other? Why are they located in neighborhoods of concentrated disadvantage? By the way, rural counties as well. It's not just black people. It's Native Americans. It's white people. We can get into that. Poverty is a thief, no matter where it is, and concentrated poverty has another additional concentrating impact of negativity. But you imagine life expectancy gets you to think about what would it mean to me and my family if we all lived 20 years less than these other people. Wealth creation, right? Think about all of the things that happen, particularly as you get mature. Wealth, wisdom, hopefully a little wisdom. So that became a way of framing it. But I want to get into this other way of framing it. When you ask yourself why people dying in Garfield Park, because I gave this analogy that if a 16-year-old teenager who lives in this neighborhood of Garfield Park, which is the most violent neighborhood in Chicago by a lot of measures, still is. It's a beautiful neighborhood, by the way. It's just it's beautiful assets. The people are amazing, but these are the stats. A 16-year-old teenage black kid in Garfield Park has a 50-50 chance of living to the age of 65. It's another way to look at life expectancy by just taking it to an individual and say, what's their chance at 16 of living to 65? About a cost of a coin. And then I ask, I've done this many times, I give a talk, say, what are the causes of death? Why is this young man dying early? And people...
I wanted to ask about that. Like, when you get your training in medicine, I mean, whether you're a coroner or whether you're a doctor, right? When someone dies, you have to provide some cause of death. And it always occurred to me that this is not a very philosophical approach to causation, right?
I know it's not.
It's usually the proximate cause that's always written down. I mean, of course, this came to attention during the COVID epidemic, where people were killed by COVID, right? I mean, a lot of the people who were killed by COVID, I mean, they were already had the deck was stacked against them long before COVID showed up, right? So as a statistician and a philosopher, you're going to look at causation very, very differently. Yeah. So how are doctors trained to think about causation, and why is it insufficient?
It's ridiculous training. First of all, I'm a social epidemiologist, so I try to think epidemiologically. I was accused when we did a paper on patient dumping many years ago as the first paper in the New England Journal of Medicine that contributed to the creation of the EMTALA Act. I was accused and my colleagues by the county board president of being a bunch of amateur sociologists. So I own my amateurness and my sociology here in epidemiology here. But I actually have a chapter in the Death Gap about this whole idea of how death certificates and causation and proximate versus root causes, for example. And I go through the whole history of how death certificates were created. And a lot of times you're called as a resident to the, medical records to sign something, and you say, what the hell do I know? And you write something down. But it's important to understand causation, and then, you don't get any real formal training on it. But oftentimes you've got to look at this and say, what are the causes of the cause? What are the causes of the causes? And so when you look at Garfield Park, just to take what's written down on death certificates, forget if it's correct or not, you looked at, and you talk about that 16-year-old, a lot of people would say, well, the reason why a 16-year-old doesn't live is because of homicide. And certainly homicide and gun violence is a big problem. But actually the number one cause of premature death listed on death certificates is cardiometabolic disease. The second is cancer. The third is infant mortality. Fourth is homicide. And the fifth is overdoses. Do you know what I mean? But when you look at the root causes of that, we told our boards, if you look at trying to understand this life expectancy gap, the first time in Russia's history anybody said that I know of, I said, it's important that you do a root cause analysis. Just like it was important as a chief medical officer to do a root cause analysis when something went wrong in the hospital. Because you do it not to find one cause, the proximate cause, but actually the 6 or 7 or 8 things that have to go wrong before harm occurs. And
so it's like the five whys that we
the
learned about the five
five
whys in business
the
school,
five
right?
whys. You ask why
Yeah.
5 times, you get to the root cause of anything. And so as a CMO, I'm translating to our board this life expectancy gap and its root causes. Again, not the proximate causes of death that I laid out, but the root causes, and said among the root causes were structural racism and economic deprivation, not poverty, but people working but not making enough money to live well. And to understand that we as an institution had at least a responsibility, if not accountability, for those economic conditions literally outside our door. And I reframed violence. It wasn't my reframing, I borrowed from others. That is a form of structural violence. That these conditions, you can look at them as economic, but it's the intersection of oftentimes race and poverty, or geography and poverty, are a form of violence in the following way. Well, number one, they are designed into our laws, our policies, our procedures, our history, of course, our norms and our values and our practices. And it's violent because people are put in harm's way and then they die early. I learned none of this in medical school.
I mean, is that simply because when you take your car to the car mechanic, right? I mean, the car mechanic isn't the guy who built the car, right? He's not the one that built the roads. He's not the one that, is it because the way in which you're trained as a doctor is to respond to problems?
Yeah, I think in part that, and in part,
I mean, you have this story where
don't
you said
ask
that
why,
if you have,
because we don't ask why 5 times, because we don't
but
ask the question why in a way. Why a car? Why not a train?
you have the story about you say that if a doctor sees a patient come in with a broken leg, 3 different patients come in with broken legs, and they've all stepped in the same pothole, the doctor should get out and fill the pothole.
Yeah.
But can
let's
doctors
get
do
on
that?
this. Yes, and so I know you teach at Stanford and I teach at Rush, and you have to sort of these institutions all. So we have to be, one of the challenges that we have in our world is we're ahistorical. We have this myth of a meritocracy. There are ways in which ideology built into a society blinds us to the structures and the realities of the world that we're in. And as a white man who had, came from concentrated advantage and placed myself into neighborhoods of concentration advantage, understood for the first time how racism and other structures were determining our work on a day-to-day basis. And we weren't asking taking a step back and asking why this was so and what needed to be done about it. And I think most of medical training is focused on, you learn mechanisms of disease, right? It's back to thinking about mechanisms of disease. Well, if I think the mechanism is a disease is your disordered biology, then the work that I have to do is to fix you. And I'm not saying that's not important work. I practice, I see the importance of it. It has high value. but it's a limited value at the same time, because if the problem that's causing your disease burden, and the disease burden in you and others who are like you, is in the way we've organized things, in our systems, in our structures, then the work has to be to, like filling that hole you mentioned, is to fix those structures. So it's a form of medicine, medical training, that I call, not the only one, social medicine. And social medicine has a number of precepts. One, it's understanding that that the systems under which people live, work, play, people call them the social determinants of health now, but the structures, including the political, economic, and social arrangements, are pathologies at time. Just like in order to eradicate malaria, it's important to understand that there's this mosquito called the female Anopheles mosquito, and any malaria eradication plan doesn't mean just sort of put netting around you, take prophylaxis. You have to address the mosquito. By the way, it's not all mosquitoes, and it's not all insects. But you have to understand that if you can't eradicate malaria without getting to the mosquito, you can't eradicate some of the diseases we're seeing, and those disease burdens, common diseases, without addressing the structures around them. And that's central to social medicine practice. And another one, big precept in social medicine, is the preferential option for the poor. Meaning, if we think about those who've been most historically marginalized in their outcomes, and then design solutions that will benefit them. It's not how we thought about COVID at all, but if we could do it that way, everybody benefits. But the counter is true as well. If we don't do that, everybody suffers. Why did more than almost 1.5 million people die in the United States from COVID, when if we were Canada, it would have been 500,000, or Australia 100,000? Because we've not organized ourselves on a preferential option for the poor.
Well, I want to get to some of these causes, because you highlight the negative consequences of poverty. But it seems like that's not enough to explain these adverse health outcomes, because, as you point out in the book, there are some poor communities in America that have average income equivalent to, say, Palestine. But, we go to look at Palestine, I mean, they live to be 73 years old, right? I mean, in other words, there are plenty of poor countries that have very low income, but which have life expectancies that are significantly higher than that of poor people in the United States. So poverty doesn't seem to be sufficient as an explanation.
No.
Right? Why are our poor people living so much less long than poor people in other parts of the world?
So I just want to say that the U.S. phenomenon of life expectancy decline preceded the pandemic, number one, and two, is not seen in any other developed country. The fact is, there's this idea of concentrated disadvantage. So here's what do we know? The work of Raj Chetty, the economist, you probably know his work, has intrigued me as I've been looking to understand this. And I can't say I completely understand it, but you're asking like a really important question. I'm going to diverge a little bit to talk about this idea of biological weathering. That if there are social pathologies, as Paul Farmer would speak about, and those social pathologies are contributing to lower life expectancy, largely through the impact of chronic disease, how are they what's the mechanism by which they're doing, and people have looked at this, many mechanisms, chronic stress, things like that, but this idea of biological weathering, that actually the chromosomes, the telomeres get shorter. And in this idea of weathering, is this also weathering means you're withstanding. So some communities, in the face of these toxic stresses, have figured out ways over time, and this is where culture and intersectionality and social networks and other sorts of things create resilience and some degree of control or autonomy over one's existence, even under duress, allows one to counter the negative impacts of weathering and actually emphasize those positive impacts of weathering. There's a whole biology of this, and because I'm not
that's about social capital and community.
Yeah, I want to get into this. Just now, how does sociology in economics connect with biology? And we can see where my mind goes in these things. So I just want to let me start with the work of Raj Chetty. So Raj Chetty has done this amazing work of connecting your income taxes with your death certificates. Simple idea. And then tracking it over generations. And so in some ways then reflecting on these associations. They're not causations, but they're associations. Where you live dictates when you die, largely as you get below median income. This is from Raj Chetty's work. If you're in the top 5% of income in the United States, you can live anywhere. Just like I mentioned before, a wealthy Palestinian in Gaza has means, hopefully, to get out. And what we see from Raj Chetty's work, that life expectancy follows a gradient. We know that from Sir Michael Marmot's work in the famous Whitehall studies in England, that independent of having universal health care, where you sit on the pecking order of administrative life in an income has an impact on life expectancy. Don't totally understand it, okay? It's just not the potato chips. I guarantee you it's not just the potato chips. But, it's not the beliefs, behaviors, and biology. It's something else, not taught in medical school. So there's a gradient.
I think Marmot controlled for things like smoking and drinking, I think.
He controlled for a lot of these things. I'm just saying for causation, if you're interested in like reframing what medical school curriculum needs to look like to address the real problem that we have today, it's not what I learned in medical school. It's not what's being taught today. But so top 5%, life expectancy in the 90s. You go down to median income, you're getting down into the 80s. Not bad. But below median income in the United States, below median income, you begin to see this divergence of life expectancy, where place begins to have an impact. And when I look at that and my naivete, I say that's the way that things like public policy, social cohesion, politics, organization makes a difference. Because why would it make a difference whether you live in New York City, San Francisco, or Birmingham? But it really does diverge. And there's, in addition to the income gradient, life expectancy we've always known about, there's a place gradient that begins to diverge below median income. So from a health perspective, I said, gosh, public policy, let's get everyone to median income. Let them spend the money, free market, let people spend the money the way they like. And that's going to be better than $7 billion into healthcare. When you take a portion of that $7 billion and invest it in a guaranteed minimum income. But I'm saying that that's one of Raj Chetty's phenomena. And he has another beautiful study that looks at what happens at age 35 to white men and black men who grew up in families that were poor, meaning the lowest 25th percentile of income. And here's another example of where you live dictates your whether or not at the age of 35 your child will make more money than you or not. And there's a chart of black America, which is largely all red, meaning almost anywhere in America where a black person lives, at the age of 35, they'll be making less than their parents, meaning downward mobility. And then a map of white America, which is largely green, except for the yellow and red of the southeast of the United States, which has experienced, that's the same area of the country, that's experienced growing steep drops in life expectancy for white people without college without college degrees. And so an epiphenomenon that started in the South for white people expanded across the country of their lived experience has the consequences. You can see it in the economics that their kids are making less than the parents, and we can see it in the death certificates. They're dying of diseases of despair. So that's the economic connection, but I want to talk about the sociologic connection now. And that's this idea of what makes a healthy community and an unhealthy community independent of poverty. The question you started with. And so I started thinking about, my community. I write about it in the book of Oak Park, Illinois, which could have flipped, like all the neighborhoods did to the east of it, from 100% white to 100% black, but put policies in place to keep it racially integrated. Somewhat controversial, but it worked as a racially integrated, somewhat socially integrated town. There's still poor and rich, and there's black and white. We haven't solved the problems. But there are trees, and there are parks, and there are, places for kids to play. And so this idea of social individual efficacy, individual capital, that comes better when you have money. The idea that I have some social capital within myself. It helps to have real capital, to have social capital, but to say, I know I can go to someone and say, can you help me? That's a social. And then there's social cohesion, where we all together can do something together. And then there's this bigger idea that's called collective efficacy. And collective efficacy is this idea of say, okay, something happened in our town. We're not going to stand for it. We're going to organize. We're going to do something. It turns out that this idea of collective efficacy can be measured. And in neighborhoods, regardless of income, that have higher collective efficacy have higher life expectancy. So what's going on in the West Bank, or what's going on in Costa Rica, is that they have more built-in structures. This is me talking as a doctor. I'm not an expert in this, but these are my observations. They have more built-in structures that encourage social cohesion and collective efficacy. And those structures and networks allow, in a crisis, for someone to reach out. Now, I'm going to take you back to how it really works on the opposite way. So during the heat wave in Chicago, it's heat. It's hot outside, as Richard Daley said at the time. It's hot, and people die, but they don't die of the heat. They were going to die anyway. But what happened were, when you looked at the deaths and who died disproportionately in black neighborhoods, disproportionately isolated people who had nailed their windows shut so they couldn't get air. People didn't have air conditioning. But more than that, no one to look in on them. So this idea of when you extract capital out of a neighborhood, meaning The Sears leaves, the Western Electric leaves, the Zenith leaves, the big companies leave because white people have left. And the bosses now, the ones who run the factory, said, I'm not going to rebuild it here. Why do I want to drive into a black neighborhood? When you take that capital out, it's not disinvestment, it's extraction. And then people are left devoid of work that's meaningful. But look at the South and the globalization. Then what happens is what sets in is, grandma gets depressed, but the uncles now are off doing something else and they don't look in on her. And so you begin to erode that social cohesion. And when it erodes to a degree that is now it's something that you could measure as concentrated disadvantage, people die.
So, it seems like there's two parts. One part is that you don't actually have anyone that can come and look in on you and help you with providing you with fans or opening your windows or taking you to the hospital. But then there's the sort of stress buffering, right? Just the awareness that you don't have that support network has a debilitating effect, right?
Yeah. Can I throw capitalism into it now? So why would Stanford or Rush put a clinic in a neighborhood like this where people are now no businesses, the work is low quality work, they're working, their insurance sucks, we can't make any money. So I'll give you a real palpable example from COVID. So, during COVID, one of the strategies, and this is where our public health strategies fail. I'll give you a few examples. I'm going to talk about COVID first. All right, we got vaccinations now. And you're all mistrustful, but we got vaccine. Go to your local CVS or Walgreens. But if you look at the map in Chicago of the Black West Side, the West Side has about 550,000 people in 10 neighborhoods. It's divided about 40% Black, 40% Latinx, and 20% white. And if you look at the Black Latinx population, maybe 250,000, be a moderate-sized city in the United States. There's not one CVS in the Black West Side of Chicago. And of course, people don't have cars. Many people have disabilities. So if you tell somebody, go to CVS and get your vaccine, you can't do it. You know what I mean? So not only, when I talk about capital extraction, health institutional capital has either been extracted. So you could look at, looks like a red line map of Chicago, except it's done as good business practice, right? And why would Stanford go into East Palo Alto? They may be. Why would you go into the poorest neighborhood of East Palo Alto if you can't make any money?
So there's a disconnect between what makes you money as a healthcare provider and what adds the biggest health impact to the community, right? So I think
yes.
I was talking to Bethany McLean. She said the hospitals make more money on knee transplants, right? Which certainly helps with quality of life, but those things, presumably the amount of resources that go into, say, a knee transplant, not knee transplant, but a knee, an artificial knee, that could provide quite a bit of impact if it were spent in a poor community.
Yeah. Coming from a background in quality and patient safety, you can translate things like racism, structural racism, economic deprivation into models that people understand from patient safety. And so the one thing is that no one is intending for harm to occur, right? It's not like the CEO of CVS, Aetna CVS, is really intending for harm to occur, just like the CEO of a hospital is not intending harm to occur to patients if that knee replacement patient gets an infection. So let's take this sort of intention. Yes, there is implicit bias, there's all these other things, but this idea of an active intention doesn't need to be there for the harm to occur. In the same way, no one's intending for these resources uh, uh, to be missing from these neighborhoods. But at the same way, this idea of attention and intention are totally missed from the picture when no one's really paying attention to what's going on. And as a result, that there's no intention because capitalism itself, racial capitalism, people have said there's this intersection between racism and capitalism. Of course, it's been there since the beginning. Why, slavery itself, well, the best labor is free labor. You want to make goods and make money off of it. The best labor is cheap labor. And of course, slavery was free labor. Colonialism was, why go through the trouble of importing slaves when we can go to the countries and produce it? But at the end of the day, the way that capitalism works today in its more modern form of it, it has no attention to the problem and no intention about trying to solve it. And why should it? Because capital's interest is to concentrate capital. And so, you've got an economic system, inextricably tied to the way we've organized the delivery system that works in complete opposition, except for that little bit of piece of it that says, your taxes and your community benefit require you to do things here or there and the other, with actually solving the problem of concentrated disadvantage and its impact on health. But there are things you can do. There are things you can do, but I'm just saying that the basic interest of capitalism and the way that it's the organizing system around how health systems make money or don't make money, keep health systems from inherently taking on the complexity of this problem. It has to be done with partners. There are ways to do it. We've created a racial health equity collaborative with hospitals and community in Chicago that's taking this on, but it's not the inherent business of a healthcare organization or even a healthcare affiliated organization like CVS Aetna to solve the problem.
Isn't part of the problem that healthcare is so darn expensive? I mean, can't we find less expensive ways of providing basic healthcare? I mean, we think about, the provision of vaccines. I mean, couldn't you just put somebody in a van and send them out? I mean, you don't need somebody who's making $500,000 a year to inject a vaccine, right? I mean, why don't we look for low cost ways of providing basic health care?
I think you raise a good question. I was just raising that the underlying economic structures do not reward the preferential option for the poor. I'm going to give you the sort of example during COVID and then get back to your question. So during COVID, because we had made this a strategy, because at Rush, when I quit being chief medical officer and a group of us, many people put together the community health needs assessment that was summarized in that discussion about life expectancy we had before our board, we decided that we were going to focus our business units on the creation of wealth in these neighborhoods. And not only that, focus on the lives of our employees, partnering with community, having community lead our efforts because we didn't feel like we had the competence to do it, nothing about us without us. And we were going to get other hospitals to join that effort in something called Westside United, which is a racial health equity collaborative of hospitals and community, looking at sort of this idea of anchor strategies of leveraging the business side of hospitals and hopefully other businesses to build community wealth and therefore health. 2 years into this idea, COVID hit, but because our hospital had made this a strategy, we understood, and we had this sort of preferential option for the poor. We're a private institution. We're a very, very high quality place. We're on the west side of Chicago. We knew that the communities that would be hit the hardest would be the black and brown ghettos and barrios outside of our doors, and that our deliberate strategy, and it's in Bethany McLean's book, was with Omar Latif, our CEO, and me calling up and texting and communicating on an ongoing basis with the CEOs and the CMOs of the safety net institutions in Chicago to say we will turn our hospital into the giant ICU because we have the capability of doing it, and we'll take the sickest of your patients. That was after failing to get the city health department to create a coordinated transfer structure. We ended up becoming extensions to a certain degree of this hospital. There were some times when we were even filled and we couldn't take them. Turns out the transferred patients were the sicker than the direct admit patients. They were Black, Latinx, uninsured. The outcomes were terrific, and our mortality experience, being a high quality place, were the lowest in the state and among the lowest in the country. We lost in the next 3 to 4 months $250 million and got very close to having our debt covenants threatened. And that's a fact. And those hospitals that took CARES money, which wasn't based on severity, right? When the federal government comes up with a solution, it tends to be, it tends to be an imprecise solution. It was based on numbers. And so some hospitals made off like bandits by not doing this. We did the right thing. We lost $250 million. We overtime.
The government,
we had to
the
lay
government
off
aid was
people.
based on volume prior to COVID, right?
Yep. I'm just saying is that the fact is that the system is designed to get the results you actually get. There's more than enough money in the system. There's ways to do it differently. The system's interests right now are so tied to profit and margin at every step of the way that the lower cost, more effective solution that has to involve some integration with public health, and to think about how would you solve the problem of Sioux Nation 3 miles away from the Upper East Side of New York. The solutions for the Upper East Side of New York are different than the solutions for a Sioux Nation, as an example, or Garfield Park in our case in Chicago. And that we have to really think about, if we really want to prevent the next pandemic, we got to really think of solutions. And I just want to take you back to 3 big public health emergencies in our recent memory, and how this disconnect between what we did and what was needed harmed people. So I'm going to start with the heat wave. The heat wave, we said to people, checking in on your families, get people out of the heat. Except it didn't take into account that there were people without families and no one to check in on them. And so they died, and people didn't have air conditioning, right? You didn't have the pre-existing condition of not having an air conditioning or a fan, and windows nailed shut because people were afraid of break-ins, led to, unprecedented premature mortality, which the city denied.
That's something that's not going to show up in someone's health record, for instance.
It's not going to show up in some health record. So let me go to Katrina. Do you know what the emergency plan, public health plan was for for New Orleans in the face of a Category 5 hurricane?
Everybody go to the Superdome who couldn't try it out.
No, they had a plan. They had actually worked out a plan before. This would be absurd enough if they didn't have a plan, but they had a plan. But the plan did not have a preferential option for the poor in it. So their plan was, when, all hell breaks loose and there's nothing else we can do, get in a car and leave New Orleans. Except 35% of the black population didn't have a car. For what was the public health message during COVID? Social isolate and work from home. which works in the Upper East Side in New York, but not if you're in the gig economy and what you can eat is based on what you can make, or if you're a frontline worker in a nursing home. So we have failed and failed and failed over and over again, despite the money in the system. And the consequence in the United States is that not only did poor people die, not only did black people, Native Americans, American Indians, and Latinx population die disproportionately to white people, but white people died disproportionately to white people in other countries because we failed to think this through. And that's, our opportunity is how do we prevent it from happening the next time, and what do we do next? And I think racial health, the collaborative life we've done is partnering hospitals with communities, really rethinking our approach to concentrated disadvantage as a matter of public policy, really thinking about things like guaranteed minimal income. Like these are questions for public policy, even in a capitalist. Listen, Canada's a capitalist country, Australia's a capitalist country. It's not just capitalism. It's the toxic form of capitalism that we have in this country that's allowed our health care delivery systems to be overly endowed with profit-making machines, holding companies, not healing companies. That's also systematically, gouged out our public health infrastructure. So it's ill-prepared to respond. And, without big public policy changes that get to how health delivery and public health work better together, but also that begin to address these underlying pieces, guaranteed medical income, universal health care. You don't have to roll in. Behavioral economics would tell you, do you know what I mean, that the best way to run to have health care for everyone is you get it, and you have to uncheck the box to not get it. There's so many simple solutions we could take, but we've not done it in this country, and I don't see us doing this, and I don't see us doing this because not only did we have the collision of the pandemic of COVID into this pre-existing social fault lines that in a pre-existing condition sort of way pre-decided who was going to live and who was going to die. But we have this giant ideological clash over the, what do you preferentially put poor people first and then organize yourself around low-cost systems that address their needs? Or do we treat this as if it's really just a meritocracy, first in line?
Well, when COVID hit, we responded with very aggressively and spent an enormous amount of resources. I think Larry Summers estimated that it was about $7 trillion in the U.S. that was spent in one way or another to address the epidemic. And as far as I can tell, the excess deaths were no different than what they would have been if we had done virtually nothing. If you were the czar of public health and someone handed you $7 trillion to improve the health of America, how would you spend it? I mean, we as economists, we think, you go where the marginal benefit per dollar spent is the highest, and then, you work your way down, right? And it seems like the way we spend our healthcare dollars is we don't follow that principle, right? There are massive benefits that can be had quite cheaply that we ignore, and then there are these relatively small incremental benefits that we spend an enormous amount of money on.
And I will posit this related to our the toxic form of capitalism that we've allowed to dominate all of our thinking. But since you gave me that platform, what are the things that I would do? None of which will happen, by the way. So I think we need universal health care because this idea of cherry picking that goes on that's racialized because white people in general have better, or people who have been assigned to whiteness have better insurance, drives the behavior of healthcare delivery, needs to be eliminated by some form of a universal healthcare. If you don't like single payer government, then Blue Cross for everybody. Like, there's a lot of ways you could do it. But I do think single payer healthcare, use behavioral economics, people enrolled at birth, you have to opt out of it if you don't want to be in it. Erwin Thaler and other people have shown economically these sort of automatic opted-in systems create the benefit. I know a minister in a church. I'm looking out my window here, and I can almost see the church steeple in Pilsen, a Mexican neighbor in this community. Lost 68 people in a church, and people were afraid to go to the hospital because they were uninsured, even though we came up with the CARES Act and covered people, and HRSA and things like that they didn't know. So that would be one. Universal health care. We know that it's a lower cost, it's cheaper over the long term. It's a better way to distribute resources across the community, blah, blah, blah. It's not the ultimate solution to everything, but it's an important thing. A guaranteed minimal income. Like, how do we leverage the thing so people have the opportunity to get to median income? I'm not sure we start at median income. I'm just telling you what the data seems to tell us, and it has to be proven out in other things. It just may be an association that when you get to median income, the impact of geographic variability goes away. High geographic variability, by the way, across the states, and how COVID, people fared with COVID, people fared with the other diseases that also went up and caused increased mortality. And the black-white gaps, or the Native American, the American Indian white gaps across every health system in the country, across every state, high degree of variability. If we could just get to the median of and that has to do with quality of care and all those complex issues, we could just get to the median of U.S. performance, we would have saved hundreds of thousands of lives in that. So those are universal health care, guaranteed minimal income. The third thing this sounds a little bit like Franklin D. Roosevelt's Second Bill of Rights, which I recommend that listeners look at. This is not radical thinking. This is actually quite central to thoughts that we've had in America for a long time, that people need, so the guaranteed income means that everyone who has a job should have a fair opportunity to make enough money. Should come with insurance, of course, with that, but they're making enough money to live. And then you would throw some other things in as, a guarantee to housing, and real security for people in their old age. And I would add the last thing is some way of better stitching together the delivery system with the public health system. I would just name those, and they're all doable. And I want to go back to Franklin Roosevelt, who led us through the Depression and led us through World War II, and he realized that the Bill of Rights that we had was political rights. But political rights don't do you much good if you don't have a set of civil rights. And that's why he proposed the Second Bill of Rights. Of course, he died and it never happened. But if you look at that Second Bill of Rights of Roosevelt, you say, yeah, this kind of makes sense. Now, they're all in the realm of public policy at the national level, which I don't think we're ever going to get to, because we have this ideological conflict. And that has led people to deny that race preferential programs to improve the health of, they call them American Indians or black people, go against would kill white people in this country. I mean, that's a bit of the ideological divide, that if we do programs that improve the health of the poor, you're taking away from me and my family. And so that ideological conflict is at the core of the reason of why we failed and why we will fail again.
I trained as a lawyer, and lawyers, at least at one point, were taught that they had duties that went beyond the duty to their client, and also went beyond their duty to make money. And I think that was the idea behind professions, right? So whether it was doctors or architects or lawyers, they were supposed to be thinking more broadly about the social consequences of their actions. Do you think that the practice of medicine has sort of lost its way, that it doesn't think in terms of what the greater good?
Yeah, think about it this way. Listen, there's always been I didn't know that law, I guess law has its own in the ministry, right? The old professions, right? Law, theology, and medicine, have in all of them a justice pillar, right? At least inherently. But when you get down to the day-to-day business of work, I want to go back to Bethany McLean's observation that orthopedic surgery paid more. But think about this: you're a health system, and so our margins, like 80% of health systems lost money. Last year maybe 70% lost money. So no one's making money here. It's not.
I mean, that's kind of astonishing given how expensive it is, right?
Right. But it's because of I think the toxic capitalism that we've allowed to dominate this. But let's just say take that as a fact. I want to say 70% or so lost money last year. A place like Rush, which is a $3 billion system, made 1% off our operating. In terms of you make more if you operate in a wealthy suburban area than you operate in an area where you've got a diverse population that includes public payers and no payers. So now imagine you're the CEO of an organization that's making a 1% margin, and the board is looking at you and saying, what the hell are you doing? And suddenly comes in, the opportunity to, two opportunities. You can go into the west side of Chicago and vaccinate people from a van using very low cost people, and that's going to cost you $10 million to do, but it's going to be great good to the neighborhoods, and you'll get a mention in the Chicago Tribune, versus making $10 million off of 200 orthopedic surgeries. On the one, you get to lose $10 million and feel good about yourself, and the other, you can make $10 million and retain your job. That's the world we live in. We lost $250 million doing good, with a CEO who had been on the job for 6 months. And his name's Omar.
So do you think that
I'm just giving you the pragmatic reality of the situation. I think we can do better. I think we must do better. I think there are many organizations, we did, that despite that, we couldn't do orthopedic surgery during that period, but we quickly got it up and going again. By May, we were doing orthopedic surgery because no one decided to change the economics of it. And it's not changed now. But I do think we can do better. I think this work of anchor institutions, the work that we're doing in the community, we're building. During COVID, I'm going to leave you with sort of an optimistic thing. So we started this racial health equity collaborative because we understood that doing business the way that we were doing it, despite the economics that rewarded orthopedic surgery over, the preferential option for the poor, we realized is an organization with a moral center and a social justice pillar, that we needed to really think about how would we organize ourselves as a health system if our goal was not to be the best in quality, but to eliminate the death gap. That's what we did in 2016. We made the elimination of the death gap the focus of our organization after we had, won the prize for being top in quality. Imagine that, that we did that, but we did it, and most organizations in the country would never do that, but we did that. And then during COVID, acted in that way, and despite losing $250 million, at the same time we realized we couldn't do it alone and created this collaborative called Westside United. 6 health systems, community leaders, really looking at what could we have influence over together over time. And we realized listen, health and healthcare is a piece of it, but it's economic vitality, it's the neighborhood safety and the built structure, it's educational opportunity. What if we could all together, we'd be the largest corporation in Illinois and begin to have impact on these 10 neighborhoods I told you about? Of course, we had a meeting about our 3-year strategic plan. It was a new organization on, I think it was March 9th, 2020. And suddenly, we were at the center of the city's racial equity rapid response to COVID. The mayor, after the first 100 deaths, 70 were black people, asked Westside United, this new collaborative that literally had just gotten together, to have partner with the city to come up with what our response should be to these racial inequities and outcomes. And our response was resources to people in the community. Up to then, it had been hospital resources, ventilators, masks, right, beds. But we said there need to be a community response, robust, money, food, the basics. And but Westside United at the same time was rolling out this economic strategy, which had to do with investing locally, in developing new businesses off our supply chain, developing new collaboratives, convening in the city around new efforts that would bring wealth creation to the community and have that community own the wealth. And there was this idea that was generated in that lowest life expectancy neighborhood I told you about, Garfield Park. We not only we take that map to our board, we had a community meeting. And we said, what do you think of this life expectancy gap? And I'm sitting at the back at Malcolm X College with a minister whose church is in that neighborhood. And he said in his booming voice, the Bible says the last should be first. And I said to him, well, we got together after. I said, well, what would you do? We started with a walk in the park there. But this ultimately led to an idea that the community had, is we want to create a wellness village in this neighborhood, lowest life expectancy neighborhood on the west side of Chicago. Martin Luther King came to it in 1966 for his Northern campaign. When he died, the commercial area went up in flames, and the embers of those flames are still burning with no investment. But the community didn't want they wanted a wellness village, and it would consist of a clinic, a YMCA, a community-owned credit union, business development unit, an art center, community grocer initiative. A far-fetched idea, and here we are during the pandemic, well, what would it look like? This is what the community wanted. But the whole idea is that the effort would bring new capital into the neighborhood. It'd be owned by the community. The income from the building, where Rush is going to have a center for community well-being, will be invested into local businesses. There'll healthcare jobs available, but also non-healthcare jobs simply by walking into this building and getting it. Credit, home ownership, entrepreneurial development, the whole schmear, right? I mean, what group of crazy people would be sitting around during the midst of a pandemic planning this idea? And then there was an opportunity to get something called the Chicago Prize, a $10 million capital prize for the best idea in the city. And this community, the south side of Chicago is the black metropolis. The west side was formed in the Great Migration. It was about 20% of the size. The toe-headed stepchild at the south side. No way we're going to get this. But we put together an application and ended up winning the Chicago Prize. And they're going to begin to break ground next spring on this complex that's going to generate, we hope, and there's other investments that have occurred because of this, an opportunity for this, for the renaissance of this neighborhood economically. So it's taking these ideas that came out of this Westside United, that hospitals and healthcare could be something different, even in the context of this crazy economic arrangements. And we think this is going to be transformative for this neighborhood, but at the same time a model for the nation of how hospitals and health systems, banks and others can actually in a material way. So we put in a lot of capital in this building. The building will be owned by the community. So the equity is going to be owned not by the hospital, not by the clinics, not by the YMCA. but the community organizations will own the equity in the building, and over time we'll be able to leverage that equity to invest in other things. It's an example of what can be done and what is being done, and I think an optimistic, in some ways, outcome of all of this.
So do we need to change the way we train doctors to think more broadly about health? Would that require that they get some exposure to sociology and epidemiology and economics
and recruit people
and all the rest?
Yeah, yes. You can see my own career transformed from biomedicine to social medicine quite successfully. That I was straight up in that executive suite. You can see I'm not wearing a tie now, but tie, white coat, starched white coat. The chief health officer really for an organization. But now in this social entrepreneurial space, right? There's an opportunity to do better. We think there's a way around value-based care and healthcare where these things start to come together. It's a big bet being put on this. It would help if others joined it. We think it's an opportunity to rethink. But imagine my training. I was trained by my patients at Cook County Hospital. I think you can organize the training around this. Like, how do you do this? How do you build coalitions? You can't fill that hole yourself. You got to get other people who are willing to do it. And it's a long-term bet, right? You have to do this thing that's called accompaniment. Another idea that Paul Farmer, but others have brought to the table is that, when someone has an illness, as a doctor, we practice accompaniment all the time, meaning I meet you at the beginning of your illness and I stick with you until you're cured or till we help you transition. It's just natural. It's attorneys, right? How you build a relationship with a client. But this can also be extended to the community, that we're going to accompany a community in its journey. And we're going to accompany its journey and actually try our best to do what they ask us to do. Not sit at the head of the table, sit at the side of the table. When we put $9 million into the Sankofa Wellness Village, our CFO did not demand that this asset sit on our books, nor did we demand that we control the direction of the project, but we accompanied the community on it. That capital is a form of repair, in a way, for the capital that's been extracted from this neighborhood. But our role is to accompany and to follow the lead of the community in trying to do what they want in the way that they want it. And that's a long-term commitment that it's hard for short-term thinking in the boardrooms to consider, because the annual budget cycle, 1 year, people aren't even doing 3-year budgets, right? 1 year budget. But we've been in Chicago for 180 years, for God's sakes. So we have to sort of figure out how we build in this long-term thinking, and then how do we train? If this is a real field, I think it is a real field, how do we train people to be experts in it? Other than, it can't be apprenticeships. It has to be pedagogy. So think of Stanford Medicine. Or we are now having in our curriculum a series of competencies that have to do with these skill sets across all of our health sciences. We're in the early phases of doing it. What are the competencies? How do you train it? What are the field experiences? Right? All of these things are critically important. You can't look back on COVID and say we haven't done something terribly wrong, but it starts with now rethinking education, as you note, another critical aspect of it.
Well, I think you said the doctors need to be the advocates for their patients in all ways. And David, you're certainly an advocate for your community and the patients who live there. Thanks so much for joining me. The book is called The Death Gap: How Inequality Kills. Thanks for joining me.
Thank you for having me, Greg.
unSILOed podcast is produced by University FM, elevating the stories of your institution.